Welcome to this video on acute trauma care in the emergency department, presented by Dr. Abdulhakam, emergency medicine consultant. In this video, we will cover trauma code activation, the surgeon's role, factors causing delays in management, and protocols for direct transfer to the operating room. Trauma remains a major global issue. Road traffic crashes cause over 1 million deaths annually and are the leading cause of death for those aged 5 to 29. Acute care surgery consists of three main facets: trauma surgery, starting in the emergency department, emergency general surgery, and critical care surgery for postoperative follow-up. A trauma team is a multidisciplinary group of healthcare workers, guided by a team leader, working together to assess and treat severely injured patients. The trauma team is an organized, multidisciplinary panel designed for efficient resuscitation. Success relies on integration and harmony between the ED and surgery teams. The emergency department team focuses on resuscitation using ATLS standards. Senior surgeons are often delegated to lead the trauma team for complex emergency cases. The ultimate goal of this multidisciplinary approach is the timely and effective resuscitation of the patient, leading to definitive care. The surgery team takes over the lead for trauma cases, determines interventions, manages definitive care, and coordinates patient disposition and critical care. While trauma surgeons were once the primary lifesavers, their role has shifted due to the growth of emergency medicine, reduced trauma rates, and improved diagnostic technologies. Level 1 trauma centers provide comprehensive total care. Notably, experienced trauma surgeons and well-trained general surgeons both play vital roles in acute care. What factors cause delays in definitive surgical management? We must examine potential delays in surgery, ICU admission, or imaging to understand their impact on mortality. Research confirms that delays in accessing the operating room for emergency surgery are significantly associated with increased mortality, longer stays, and higher costs. Interestingly, some studies suggest that delays in ICU admission from the emergency department may not be directly linked to adverse mortality outcomes. Finally, essential bedside investigations like blood grouping, fast scans, and standard X-rays are critical for early assessment and should not delay patient management. CT scans are standard for trauma, but we must be cautious. Research shows that delaying surgery for a CT scan in hypotensive patients with severe abdominal injuries can increase mortality. Various factors can delay definitive surgery, including pre-hospital delays, imaging performed at peripheral hospitals, and hesitation in activating the trauma code or making critical decisions. For certain patients, the best approach is bypassing the emergency department entirely. Directly transferring to the operating room for resuscitation can be life-saving for those in severe shock. A recent systematic review identified thousands of patients and confirmed that direct operating room transfer significantly reduces the time to surgical intervention compared to standard pathways. To avoid over-triage, the American College of Surgeons has simplified criteria for direct-to-OR decisions, focusing on penetrating truncal mechanisms, critical anatomy, or profound physiological shock. Thank you for joining this presentation on acute trauma care. Remember, as the saying goes, a good surgeon needs an eagle's eye, a lion's heart, and a lady's hand.